We're so glad that you're here. Thank you so much for making the time. Welcome, welcome. I'm here with such a powerhouse group of folks for our first Risk to Reasons formal idea exchange, and really want to appreciate everybody who has made the time to be here. We are really excited to help mark and help make really this moment where we as a movement are prioritizing providers and public health folks to help reframe risk away from the fear and stigma and towards the reasons, the motivating reasons for Black women to engage in HIV prevention and care. So welcome. My name is Amelia Karangi. I use she, her pronouns, and I am the Director of External Affairs Strategy and Programs at ViiV Healthcare in the US. And I lead our community giving work, including our commitment to women and the Risk to Reasons initiative. And I am here to help us move through this exciting conversation with these tremendous women that I am sharing squares with. And all of you online, I think we should take a moment to recognize all of the amazing leaders and thinkers and folks in the movement out there that have joined and are joining this conversation more every moment. I think there are folks from all over the world here, certainly from so many walks of life, from physicians to health departments I see on the line, to members of CFARs and AATCs, to I see folks committed to harm reduction work globally and ending the housing crisis who have joined us. I see navigators and nurses. So just welcome into this conversation. Welcome into this moment. Thanks for being here. Thanks for being sort of the bright spots in this moment right now who are going to help us move this work forward. And thank you to the team that's put this together and our colleagues at TCC Group. And thank you to the Black Women's Working Group. I know many of them are on screen right now and also online. So just love and appreciation to the full Black Women's Working Group to Reframe Risk. We're glad you're here. We're going to spend our time today talking about the Risk to Reasons initiative and the elements of this movement right now where there's a lot of energy and excitement, and in particular, the resources that are available for providers and public health folks to reframe risk in your practices. We will hear from members of the Black Women's Working Group, as well as our colleagues and leaders at the CDC and at health departments, as well as our grant partners who are doing amazing work in communities across the country. We're here to share ideas, build momentum. We hope the chat is active. We are recording this conversation, and we are really, really interested in what this sparks for you. So please consider this an open invitation for dialogue as we're moving forward. So Risk to Reasons is designed to reframe and refocus HIV prevention for Black women by fueling new messages, new messengers, and new methods, new ways of communicating and connecting with Black women around HIV prevention and care. And to help us set the stage of why this work is important to ViiV and who ViiV Healthcare is, I've invited one of the many champions in our company, the head of ViiV's R&D, Dr. Kimberly Smith, to join us in the welcome. So Kim, over to you.
Thank you, Amelia. This is wonderful. I'm so happy to be here. I love seeing the names flying by. I love all of the faces in front of me, and I'm super excited to be here. As Amelia said, I'm Dr. Kimberly Smith, Head of Research and Development for ViiV Healthcare. And I'll tell you a little bit about ViiV. We are the only company that's 100% focused on developing medicines for HIV treatment and prevention. And that makes us feel like we have a unique commitment that is above and beyond anything else, that we have to go deeper because HIV is our 100% focus. And we are 100% focused on women. You won't find too many pharmaceutical companies that have a Black woman as the head of R&D. I'm gonna just tell you that. I think y'all probably know. But I'm going to just remind you of that. We also have a CEO that's a woman. We have our our chief medical officer is a woman. Women lead our company, and our commitment to women is from the top throughout the organization. And that means that we understand the need to do this differently than it's been done in the past. And so we're here to support the Risk to Reasons movement. And I explicitly use the word movement among healthcare providers and folks who work in public health. Because if not us, who? And if not now, when? I know that there are already folks that are out there that are already early adopters, that are champions of really this strategy to change the way we talk about HIV and to really change the conversation from risk, to take away the judgment, to take away the stigma, to open up the conversation in a way that is completely different. Because we have been on all sides of this conversation. We've been the providers providing care, but we've also been the women who have been seeking care, and in many cases not getting what we sought. We have been the folks who have been educators, and we've been the folks who have been seeking knowledge. We have been the folks who were the shoulder to cry on, and we have been the folks who needed a place to cry, or a good cry. And so this is the opportunity for us to come together, to really raise our voices together, to really elevate the urgency, the need for change, to start to make it feel like every time a woman in particular, every time a Black woman is diagnosed with HIV, that means we missed something and that we should have done better. We maybe could have done better. And so let's do everything that we can so that we don't have regret. And so I'm super excited to be here with this unbelievable, incredible group of brilliant women who will share their thoughts. And I hope that everybody who's participating gets something really new and thrilling out of this that makes you feel more and more motivated to really move the needle, to change the game, so that we can really get to a point where we feel like we have this under control, because those who think that we do are wrong. We still have a whole lot of work to do. And so I'm so excited to kick this off. I want everybody to think about what you can contribute today to this conversation and what you can take away from the conversation and take away to deliver to your colleagues. And so with that, I'll turn it back to you, Amelia, to kick off the rest of the show.
Thank you. Thank you. Thank you. Thanks for being here. Thanks for championing the work and making sure that women are included in all the different ways that we need to be across ViiV healthcare. And so I'm going to take just a couple minutes because I know there are folks on the line with varying degrees of connection to the Risk to Reasons movement. So I'm going to orient us into what we started a few years ago in partnership with community before we dive into our first conversation. So with that, I think there's been this long call from the movement, like really a very long call from the movement to reframe risk, that it is stigmatizing, it's scary, it, positions folks in a sort of shame and blame scenario rather than helping people really understand how they might benefit from HIV prevention and care. And so as part of our Positive Action for Women commitment, we took on this challenge that has been to reframe risk, and we pulled together the Black Women's Working Group to Reframe Risk, which are a collection of the longtime angels in the movement, of emerging leaders, of kind of the local lifesaver hookup if somebody's looking for care. And we came together over a year to talk about what does it mean to reframe risk? How might we reframe risk? And where we landed was this beautiful, very simple piece, this very simple offering, where instead of talking about risk, We are suggesting we instead talk about the reasons for HIV prevention and care, and women with reasons for HIV prevention and care. And there's a couple of important pieces here. One is that when we say women, we mean all women, including women of trans experience. And two, when we're talking about risk to reasons, we are talking about prevention and care. And we believe that we can do both and that we must do both if we're going to meet the urgent needs for Black women right now in the US. And so Risk to Reasons has been putting out new content that we'll talk about over the past several years that's designed for women in community, that's designed for folks doing the work in organizations. And now that you'll hear is designed for providers as well. We've been funding community action, and we've been doing our part to connect the movement. This idea exchange is some of that connectivity that we're helping to bring to go further, faster together. We put the recommendations from the Black Women's Working Group in a communications guide, which is free and available. And we'll dig into some of the contents of this initiative over the next hour or so, but really has been grounded in guiding values that are critical to connecting with Black women and are focused on three motivating reasons for HIV prevention. The first one is around power and circumstances and control as a real reason for women to engage in HIV prevention and care. The second reason is around intimacy and desire and pleasure as a reason to engage in HIV prevention and care. And the third is about normalizing self-care and really thinking about HIV prevention and care as a way to take care of women's whole self and well-being. We also made the largest philanthropic commitment for Black women around HIV prevention in the US, and we resourced more than 18 different projects with more than $8 million designed to engage women in communities of high need, to train organizations and providers to better meet their needs, and to do all we could to change the narrative in our culture around HIV prevention for Black women. And I gotta say, it feels really different than it did 2 years ago. A collection of us may have come together and launched this initiative maybe 2 years ago, and it was quite different. And so I think in your own spheres, in your own places, just take a moment to recognize all you've contributed over the past couple of years to get to a place where I think the movement and where Black women in particular are stepping into power and into places in different ways. And this moment that we have right here is another example of what feels quite different. So thank you to all of our grant partners and all of the many, many messengers across the country. We have reached more than 10,000 Black women. More than 7,000 activity books have been distributed directly reaching Black women. There have been almost 70 events across the country in the past year or so. And we have public figures from T.S. Madison to Beyonce's mom and Anika Noni Rose talking about women's reasons for HIV prevention. We know that so much of this work is really nestled in public health and organizations and providers that are able to respond when women move forward and come forward. And we have been resourcing different training opportunities for organizations across the country to learn more about women's needs and to think about how they might adapt the Risk to Reasons recommendations. And we have done everything that we could and that we will continue to do to change the narrative, from our communications muscles to independent journals that folks on the line, I know there's so many researchers on the line, have taken these recommendations from the Black Women's Working Group, published findings, and are moving this content out into the world in very wonderful and creative ways. So huge thank you to everybody who's taking a simple offering of reasons instead of risks and going with it where you can. That's what we're hoping to do a little bit more of today. I want to make sure that everybody has access to these two resources in particular. The first is the Risk to Reasons Guide. These are recommendations for organizations, providers, media makers about the specific reasons for HIV prevention. We've also created a series of activity books, which are designed for use by women across the country. They're being used by thousands of women every day, every year. I think thousands of women are using these activities to have conversations with yourself, with your partner, and with your provider around your sexual health and HIV prevention needs. And so these are also available free to download. One of the most amazing things about Risk to Reasons as a movement is that there's different elements that get to be built on and expand, and the ripples go forward and forward and forward. So this is an opportunity for folks on the line to, put yourself in this movement in the right way for you. At the center is the working group and the advice of so many Black women who have guided this initiative, complemented by the work of grant partners and of our external affairs community liaison team, as well as our work on a national level and our commitment to medical education that all gets supported and connected through this very large network across the country. So if this is the first time we're getting a chance to connect to you, welcome in, and thank you for being here. So with that, I am going to invite our first crew up for the conversation. I think we can take the slides down, please. And we're going to start really where we need to start, which is focused on women's reasons for HIV prevention and women's experiences. So I am excited to reintroduce the wonderful Olivia Ford from the Well Project and a member of the Black Women's Working Group, and Beverly Ross, who is a prevention specialist and advocate in Chicago, to join the conversation. Hello and welcome. Just want to make sure that our view is good to go here. Yes, we've got the right folks. Hooray. So welcome, Bev. Welcome, Olivia. I'm so glad you're here.
Yes, I'm so grateful. I'm happy.
Thanks for being here. So we're going to start at the top. Why? Why does it matter to reframe risk? Olivia, I'm going to start with you. Why do we have to reframe risk?
Thank you so much, first of all, for having us all here. It's always just such an honor and a pleasure to be in this circle and just be having this conversation. Just taking it from the top, considering that this is an audience of providers and public health folks and folks working in this field and living in this community. I think as people in this community, as providers, practitioners, we tend to want to find and lean into what works, and the language of risk to describe people's life experiences relating to HIV has not been working for a long time for Black women and for many others as well. We focus on Black women, but it's not exclusive to us. The way that I can enter this conversation as editor, writer, communicator, being part of this community and in intersecting spaces for a while now. I know that with the language that we use to talk about HIV, talk about health, sex, systems of repression, pleasure, just shapes our sense of reality. It shapes our sense of ourselves, our decision making. And I know also from experience that our field is capable of change around language for the benefit of our people, and that we can do it again here. And from that perspective of health spaces, it's really reframing risk is really this chance to affirm all of our shared humanity. It's just to shift away from this tendency to pathologize health conditions, and hopefully just invites providers and public health folks to let go of, if there's a part of their training that's about distance or alienation from people who are receiving the care or the services they provide, to kind of strip away some of those layers as well.
Mm-hmm. What about you, Bev? Why is it important to you that we reframe risk?
I believe it's important to reframe risk to reasons. I believe it's essential because the language we use kind of shapes our perceptions and actions. We talk about risk, and it's often like we're pointing fingers and placing blame, especially on marginalized groups like women of color. And I believe if we shift these conversations to reasons, we're taking time out to understand, motivations and challenges and circumstances that influence a person's decisions. And when we say decisions, it also can reduce stigma, but also open up the door for more compassionate and effective care. Because once I always say is when you are getting that diagnosis, I think as providers, it's okay to kind of like break down from the provider standpoint and be more personable. And I think it's better focusing on how to connect with patients on a deeper level, understanding their needs and supporting them can kind of truly resonate with their lived experience.
Hmm. And when you think about the reasons for HIV prevention that are most important to lift up right now, where do you start, Bev?
I want to say, as a Black trans woman and a CEO of my own nonprofit, my reasons are deeply rooted, like in both of my personal journey and the community that I serve, right? I've seen like kind of like firsthand how stigma and judgment can prevent people, particularly women of color, from accessing the care that they kind of like need, right? To be able to have those conversations with their providers around prevention. And I always say there are three levels to prevention. So my reason is kind of like creating a space where people can feel seen, understood, and supported for many of like my community. Accessing healthcare can also be a stepping battle, but if we start, understanding the reasons, and I believe like the stories, the struggles, and the strength, we can provide care. Well, the providers can provide care. That doesn't just treat the body, but also like help heal the spirit as well. Yes.
What do you think, Olivia? What are the reasons that are standing out to you right now in terms of reasons for HIV prevention or reasons why to have this conversation?
Yeah. I think that, what my thoughts really track with Bev's, just again as a Black woman, just being in this world and in this work and being part of this community. I know it comes up over and over again in folks' work that those circumstances that Black women and so many of us didn't choose for ourselves are our reasons for HIV prevention, whether that's generations of being inadequately served by healthcare systems, or whether it's being unhoused in this moment, or experiencing violence, or any of those other kind of structural circumstances. And then really also, in any context on an individual level, the way that those reasons play out is that, those reasons for HIV prevention may be, and for care as well, may be part of how I'm surviving, but they also may be part of how I feel a sense of connection, maybe part of how I experience pleasure. And it feels important to lift up those really just extraordinarily, again, just human, repeatable experiences that I would say that, was can identify with.
Mm-hmm. Bev, you often talk about possibility or probability as a reason you'd like to lift up. You want to say a little bit more about that?
Yes. That's a really good. You got me on the spot. I think it's great that we be able to change the language, and I believe firsthand I was able to be a part of this working group so that we can be able to, change the language. And I want to just share with you guys about 3 levels of prevention. Well, could be used for prevention. It is being HIV probable, possible, and positive. And probable is unaware prevention. I often talk to women all the time about HIV in general. And I also always acknowledge that we are living with an immune system, and we're possible for HIV. So basically, probable is unaware of prevention. Possible is aware of risk, but we're going to say reasons for HIV, right? And HIV possible is what we're not trying to, get to, but it happens because of the reasons of HIV and just in general HIV. So those are the 3 languages I want to be able to like uplift and be able to use, and also train providers on what that look like, I believe that is very important, because when people look at HIV or hear HIV, it's become a scare tactic around that word, that phrase. And I think that's important that we are able to like learn how to live this language around prevention. I think that's very important. And hopefully that's something that I can be able to, promote more moving forward.
Mm-hmm. Mm-hmm. And there's a piece around the probability and where you live, and helping women understand sort of some of the environment around them that may like really amplify some reasons for HIV prevention that I think we're working to raise awareness of. When you think about how the landscape's changing right now, you both have been in this work for a really long time. What's changing? What's different about the prevention and care landscape right now from your perspective? Go ahead, Olivia.
Apologies, I had one of those few seconds issues getting off of mute. Thanks for asking. I mean, again, I think that it's still, it's still a long haul, but I think that there's a lot more. I'm going to lift up my comrade and sister Bridget Ku's comment in this chat just a minute ago around just supporting the power and agency and bodily autonomy of women to control their own dictating of their own experience, their own speaking of their own experience. And I've seen a lot. There's a lot more. That message is a lot more forward, I'd say, and it's a lot more matter of fact, I think, that maybe it was many years ago when I first encountered this community, when I first became part of this community. Though again, oftentimes it's still in the context of being able to sort of connect with like-minded people and demand that be that intention be supported in these prevention and care spaces. Also just want to lift up briefly, like in recent years, kind of the evolution and acceptance around status neutral approaches, which came in kind of your intro to our conversation, Amelia. It's been promising as far as starting on that journey of kind of normalizing and integrating HIV prevention and care into women's overall, into just in general, into overall healthcare wellness experiences. Though also just it's important for that kind of integration to be on a balance with sort of not integrating out of existence, or away from sort of the crucial need for resources to support our intersecting communities in particular ways. There's a lot of nuance to these conversations and to this movement around normalizing HIV. That doesn't mean we don't talk about it. That doesn't mean we don't recognize the importance of continuing to have prevention care or reasons to be part of even more conversation. It's not about being more in the background, but being more having more of that kind of power and agency in our community's voices, and in many more conversations. I'll stop there.
Right. Yeah, I think that piece around integration doesn't mean dissolving it out is one of those tensions that I think we're all learning how to hold, and that we all have to hold when we're talking about normalizing HIV conversations, and also making sure that they are there and they're supported and that people are prepared when those conversations come forward. What about you, Bev? What are you saying? What's different around HIV prevention and care for Black women in the landscape right now?
I want to highlight Kimberly Smith, Dr. Kimberly. She said something around the lines like stigma, and I always say that HIV doesn't kill. And if HIV is still killing folks, especially women of color, I want to say that it's stigma. Stigma is what kills people that are living with HIV, not HIV. And I talk about the landscape of prevention and care is changing in ways that are both challenging and also promising. I feel like we're seeing like a shift towards more personalized, patient-centered, that recognizes the diversity amongst different lived experience. And I think we have to always be mindful of that. And this includes like the knowledge of social determinants, those, disparities, those health disparities. and those kind of like factor around like behind the health behaviors that we are making that are often kind of like overlooked. And yeah, that's pretty much so. Like, yeah.
Yeah. And I think there has been a bit of a shift too in what you're saying around, there is more attention to pay to looking at the person in front of you, understanding different circumstances, taking the time to understand different circumstances, to listen for reasons, and to share some of the options and the choices. I think that's where we're trying to go. So we're trying to help folks listen for the reasons and share the options and make sure people have choices when
Yeah,
are seeking sexual health services broadly.
yeah, I think we have to get away from that shift, shift from like that one size fit all approach.
Mhm.
That's that's kind of like played out. No shade. And I believe that it honors to meet individual stories and meet people where they are. And I think it's very crucial because it's not just about treating a disease, it's about promoting overall well-being, and resilience in our community.
That's right. That's right. The well-being and the resilience is a motivating reason for this conversation. All right. I appreciate your ideas and the ways that you've exchanged them. Thanks for playing and participating in our first segment. I am going to invite a few more folks into the conversation. And want to introduce Dr. Robin Fanfare, who is the director of the Division of HIV Prevention within the National Center for HIV, Viral Hepatitis, STD, and TB Prevention at the CDC. Welcome, Dr. Fanfare. We're glad you're here. I wanted to open it up to you to introduce yourself and share a little bit about the landscape right now as you see it before we dive into a little bit of a conversation. So welcome. Thanks for
Absolutely.
being
Thank
here.
you. Thank you so much for having me. It's a pleasure to be here. As you said, well, first I'll start and say I use she, her pronouns. I'm thrilled to be here as the director at the Division of HIV Prevention. And as Dr. Smith was talking about history, the first woman and first Black woman to serve in this position. So thank you so much for having me. In addition to that, I also serve as a provider for veterans with HIV here in Atlanta. So just kind of starting with a little bit of the framework for what is happening right now with HIV in Black women. And I think it's so critical before we talk about any of the disparities and any of the inequities that we're seeing that we really start with why they exist. So much is because of the intersection of race, gender, socioeconomic factors that continue to have a huge impact on the rates of HIV that we're seeing in Black women. Social and economic issues such as racism, stigma, misogyny, housing, employment, income inequality, all can prevent access and receipt of high quality HIV healthcare, including testing, treatment, and prevention. So what does the data show? In May of this year, we released our most up-to-date surveillance reports, and this is for the data through 2022. So among women aged 13 of years in the United States or higher, approximately 50% of diagnoses are among Black females, although we only account for 13% of the population. Put another way, the rate of new HIV infections among Black women is 10 times that of white women. Now, from 2018 to 2022, we have seen the rates of perinatally acquired HIV infections among persons in the US reduce significantly. However, most perinatal HIV diagnoses continue to be among Black women and impact our babies. So turning to HIV treatment, people with HIV who take HIV medicine as prescribed and get and stay undetectable will not transmit HIV to their sexual partners and can live a long and healthy life. U equals U. Untransmittable, undetectable equals untransmittable. So in 2022, nationally, 76% of people diagnosed with HIV have received some type of HIV care, and 65% are virally suppressed. If we look specifically among women, 75% of women diagnosed with HIV have received HIV care, and 64% were virally suppressed. Now, what about PrEP? Overall, there have been increases in PrEP prescriptions among people who could benefit, and it shows that people in the United States who have been prescribed PrEP has increased. However, despite this overall increase in the number of people in the US prescribed PrEP, the reach of this strategy is far from equal and substantial disparities persist. Efforts to increase access to PrEP must be further strengthened and expanded to reach all populations, including Black women, equitably and to eliminate racial, ethnic, gender, and geographic disparities that persist for this game-changing, life-saving intervention. So I'll just highlight just a few CDC programs that are focused on improving health equity and addressing HIV-related outcomes for Black women. First is a project called Her PrEP. This looks to increase PrEP use among Black women in the United States. It plans to evaluate the effectiveness of implementation strategies to increase PrEP use among Black women in women's health clinics. Exploring preferences for long-acting antiretroviral therapies. This is a community-based sample, specifically of cisgender Black women living with HIV, and seeks to create equitable access for HIV treatment and care for women with HIV. And City Match. This is the elimination of perinatal HIV task force, where stakeholders come together to improve perinatal HIV surveillance, improve preconception care for women with for people with HIV, and develop a roadmap and reproductive health tools for people with HIV across their lifetime. And finally, our Let's Stop HIV Together campaign launched a new initiative called #She'sWell, which is focused specifically on increasing awareness among women about PrEP, building capacity among clinicians and providers to feel empowered and confident to prescribe PrEP to women who can benefit, and ultimately increase PrEP use among women. Finally, we have our compendium of evidence-based interventions with best practices for HIV prevention, with interventions specific for women, where community-based organizations can tailor to help meet the needs of Black women in their communities. For our providers, we have clinical ambassadors, one of whom you'll meet soon, who are vital to promoting efforts to increase HIV awareness, reduce HIV stigma, and promote HIV prevention, testing, and treatment. As part of Let's Stop HIV Together, we partner with these nationally recognized clinical care experts, such as Dr. Oni, to promote the campaign and encourage clinicians to access HIV Nexus resources. So what's HIV Nexus? This serves as a one-stop shop for information across the HIV prevention and care compendium, including up-to-date tools and guidelines and educational materials for providers. So in closing, looking forward to our discussion, at CDC, we recognize that policies make it difficult to navigate systems that perpetuate structural racism and impact the needs of Black women in HIV prevention and care. These are policies that impede access to affordable and quality health care, comprehensive, medically accurate, age-appropriate sex education. Where are our kids getting sex education these days? We have to look at the need for cultural competency training for healthcare providers and trauma-informed care. And finally, addressing social drivers of health, such as housing, criminal justice reform, and increased access to mental health services are essential for comprehensive strategy to address the disproportionate rates of HIV that continue to impact Black women in this country. Back to you, Amelia.
Thank you, Dr. Fanfare. It's refreshing to hear all of the resources that you have available, and we hope and thank you, Sloan, in the chat for making sure that they're available here. We hope people will tune in and connect to what's there. Nobody is starting from scratch or anywhere near it when it comes to meeting the needs of Black women. I want to invite two of our friends into the conversation. Dr. Oni Blackstock, who is the founder and executive director of Health Justice, and Miss Leisha McKinley Beach, who is a renowned activist and advocate and member of the Black Women's Working Group. Welcome. Thanks for joining our chat. So I'm going to start with you, Dr. Blackstock. Tell me a little bit about why it's hard. Why is it challenging to move from risk for providers and public health folks?
Yeah, totally. Well, just want to say I'm so excited to be here. I'm so glad we have our fearless leader, Dr. Fanfare, who's going to get us into that last mile, and we're going to be ending the epidemic together. So wonderful to have her leadership here, and so happy to be in conversation with all of you. So, I mean, I think if I asked for folks to put in the chat, like how many of you, came to your current role or stay in your current role because you want to provide affirming HIV care or HIV prevention, like everyone would probably say yes. Like this is what we all want. We want our patients to feel affirmed and validated and seen and to feel empowered. At the same time, we know that we, for instance, for clinical providers, clinical providers may be challenged by time when they're seeing patients, by resources. They may not feel like HIV or sexual health has a lot to do with what they're tasked with. So that can be challenging. Also, we may feel uncomfortable talking about sexual health with our patients because that means talking about sexuality, sexual practices, behavior. It may be about drug use behaviors if we're also talking about HIV. And the reality is that for many of us, the training that we had sort of early on in our careers, that actually hasn't really shifted that much for current practitioners. So we're really needing a shift and a paradigm change in how we are talking about sexual health with our patients. We also may not be aware of what opportunities and resources are out there for us to sort of develop and cultivate those skills to have these conversations, either with our patients or with our clients or with the communities that we are serving. So I think all of those play a role. And I was thinking back to our prep call. I know Dr. Kimberly Smith had mentioned, this vulnerability that we can tap into also as practitioners, as clinical practitioners, as service providers, that acknowledging that we may feel uncomfortable with these conversations, but that may be a place to start from to really sort of feed, our motivation to have like really affirming and validating conversations with our patients. That's really our duty. And I think we, as has been alluded to, I've said this before, and many people have also said this, that we've come from a perspective of what's the matter with you, with our patients, really pathologizing our patients, as opposed to what matters to you. Like, what are your priorities? What are your motivations? What are your needs? And we know that when patients, for instance, have positive engagement with healthcare providers, that promotes prevention and care engagement. Patients and clients actually want to talk about sexual health, but they want to do it in a way, in a container that feels safe to them and affirming to them. So I will stop there and bounce it back to you.
That's true. There is a vulnerability, I think, for everybody involved in the conversation. And it's a good level set to sort of remember and embrace that a person has to express that vulnerability, and also that providers have to express, feel a little vulnerable potentially in that moment as well. So, Leisha, what about you? Why do you think it's so hard in so many ways for providers in public health to talk about and provide the affirming HIV prevention and care?
Well, Amelia, I don't know that there is much more to add after hearing Dr. Blackstock and Dr. Fanfare. The first thing, though, that I will say is seeing both of these amazing, brilliant Black physicians is evidence that it is possible. I'm pulling out of Ms. Bear's playbook. It is possible to have providers have the conversation with women. And I often think, well, first let me do this. I'm so excited and I'm starstruck for real. So I just mentioned 2 providers. You can't list them. Dr. Robin Fanfare, who has occupied space and has shown us from day one that women matter to her. And Dr. Oni Blackstock, who has led by example, right? The how-to do. That is not impossible to have conversations with women about their sexual health, about their health care, and about their mental health, because those 2 go together. And so I'm acknowledging too. I want you to acknowledge in the chat, who are those providers? And we use that term loosely, could mean case managers, and other types of providers. But right now, I want to uplift MDs, I want to uplift MDs. Who are those MDs that when you think about, they have gotten it right? They know how to center women in the conversation. They know how to uplift. I see them coming in. Dr. Tasha, thank y'all. They know how to implement cultural humility so it doesn't look like this, that I am the provider and I know it all and you just follow what I say, but it looks more like this. Yes, I've got the medical expertise, but you have the expertise of living in this body your whole life, right? And when we bring those two together, there is an amazing plan that we can design for those who are HIV negative to maintain the status that they desire. Oftentimes, we have providers who, I agree, sometimes it's a time issue, but other times I am very uncomfortable. Look at all of those providers that the participants are saying they are not uncomfortable, right? That they recognize that this moment, these 15 minutes that they have with me might be the only 15 minutes where they get to be vulnerable and share what's going on with me sexually. I made a comment last year, it might have been 2 years ago. Risk to Reasons has, launched off in such a huge way that I have forgotten like how long we've been at this, right? But I made a comment that I still stand by to this day as it relates to women. If we're gonna see a scale up of PrEP use because of PrEP need among women, particularly Black women, we have to come outside of the HIV model. And what I mean by that is that there are more of us who will see our primary care provider, a gynecologist, the attending physician in the emergency department before we are seeing providers in our health departments, in our AIDS service organizations. It just is what it is, right? And so imagine when I go to those providers that there is this continuity of conversation around sexual health. I use my daughter and I as an example that in the past year, both of us have seen a provider, but neither one of us saw that provider at an AIDS service organization or at a health department, right? And so if we're not expanding the model that both of our esteemed physicians just described, then we are not committed to this scale up to make sure that Black women have the same access that everybody else has. And just because I am done, don't stop uplifting these amazing physicians in the chat. I see Painting the City, Mahogany Blue. I know that is from Detroit or Michigan. I want to give you your shout out while I got this mic for 10 more seconds. Some amazing campaigns are raising awareness for Black women that these types of providers like Dr. Fanfare and Dr. Blackstock, they exist.
That's
so thank you. Thank you.
That's right. Thank you, Alicia. Thanks for calling in a lot of the amazing campaign work that's happening across the country. Dr. Fanfare, do you want to talk a little bit about what you're seeing, what's working well to change the narrative, where you see opportunities in public health departments for Black women?
I think a lot of what has been addressed as some of the challenges is what I'm starting to see in the movement. So some is that expansion and breaking down of silos, right? It's so important if we really think of HIV overall is one of the justice issues of our time, it's aligned in the conversations we should be having about reproductive justice. We should be having about public health justice. It's not just about HIV. And so I think one of the things we've been seeing is that broadening of the work that we're doing, health departments are doing, community-based organizations are doing to try to break down those silos. Because I believe that one thing we do as Black women is we do access healthcare, right? We do go and we make sure that our partners and people that we love go as well. So it's important that when I am seeking, which might be my primary care provider or might be my OBGYN, that they feel that they can have those conversations. Because the truth is that in some spaces, we've done a fair amount of community engagement, and I'm sure people here just living these experiences, sometimes it's providers we can serve as gatekeepers, right? So even when someone has done the work on their end to feel like, wow, I've done the research, I want PrEP, and then you go in and you're met with the question, well, why do you need PrEP? Or some people tell me about PrEP when they come to the provider. And so I think one of the things we've been seeing is really the breaking down of the silos, the broadening of the workforce. I am so thrilled to be here with my sis and making up the less than 3% of physicians who are Black women in this country. But, you know, we have to broaden the fields who are also doing this. We have to bring in our nurses, our PAs, our pharmacists, and really continue to broaden the workforce to be doing this work. And then I think it's just important to, which is why I love Risk to Reasons, is, you know, take it into the sexual health, the well-being, the self-love, the self-care. Those are terms that I use and that resonates with me. If you start talking to me about risk, I'm done. And you've missed that opportunity. So I think that that's really important. And the last thing I'd say is, and I think Oni had said this, about what matters to them. And I think about the women who I see in my practice. And sometimes we're not talking about what's going on with your art. This is what's the latest with your CD4 count and viral suppression. We'll get there. But we're talking about, you know, your granddaughter's graduation, or you're teaching me about how you use fish head to garden your tomatoes. Like, that's what's important to you. And that's what helps build the relationship. And so I think that that's really important as well.
So it's so true. I think that once you see all the places where it can go, you know, in your role as an advocate to move the messages through, and how it provides some language in a place that otherwise, you know, isn't part of the conversation. I think it's a step by step. And sometimes it feels too slow, but I think the step by step, you know, nurse, provider, MD, case manager, I think every single touch point is an opportunity to just try a little bit, and see if there's something else that feels more comfortable. So Dr. Blackstock, you've been talking about how Risk to Reasons helps providers. What do you think needs to happen next to get us outside of HIV? When you think about training providers, when you think about encouraging conversations of sexual health, what needs to happen next?
Right. Yeah, I think a lot of it is getting folks practicing these new sort of behaviors, new terminology. I think we've talked about, you know, shifts in language. So when we use terms like risky or high risk with our patients, like how much that disconnects us from our patients and how much patients might disengage from that conversation, understandably. So I think like having, for instance, the activity guide, I have gone to the activity guide for providers that Risk to Reasons has, because there are the sample messaging in there about how to really affirm our patients, how to sort of reflect back to them what they're saying. Like, it sounds like you're saying that, you know, having control or feeling empowered is really important in your sexual health. So just also having the language that we can use to talk to our patients, I think will also make us feel better. I mean, I'll just talk for medical providers. I think a lot of times we'd like to have sort of the tools that we can pull out really quickly. So having some of those go-to questions, for instance, like, tell me a little bit about your sex life. When I've said that, people are like, wait, what? I don't know. Because usually you start with, well, how many partners do you have? But then it becomes sort of this checkoff list. And it makes people think that your number of partners or who you've been with is what puts you at risk, when we know there are many factors that can place patients at increased vulnerability. So it's some of that shifting our language, which I know Risk to Reasons talks a lot about, and just our approach, right? So we've talked about what is the why for our patients. We know that emphasizing benefits more than risks actually motivates folks more. So figuring out whether it's about like enhancing intimacy so that you have less worry, so you're able to focus more on having a pleasurable experience. So figuring out what that why is, I think, is incredibly important. And it doesn't take much. I think it's these open-ended questions, reflecting back what you're hearing. And then if there are specific questions you want to ask around, number of partners, sometimes people will just share that with you if you ask these open-ended questions. Like you don't have to ask those pointed questions unless you've sort of had these, this in-depth conversation. You're like, oh, we'd love to learn more about X, Y, Z. So I think it's about our approach and normalizing the discussion of sexual health as being part of our overall health.
And what if if you're a provider, you're a nurse practitioner, you've never really talked about sex with any of your clients? Why should you start, Dr. Blackstock? What's your...
Well, I think like we said, no, that sort of this preamble that I usually use with my patients is like, I'm going to ask you some questions about, your sexual health, any concerns that you might have. And this is what I do with all my patients. Sexual health is part of overall health. And it helps me to take better care of you if I know, what your concerns are, what your questions are. So I think we do things in a way that's like patient-centered or client-centered. Like it's always going to have, I think, a benefit. And if we approach it with care, obviously in consideration and respect, that's also incredibly important. But I think it's also just picking one thing that you try out each time in an encounter. Like, I'm going to try out this question and see what happens, or this framing. And then sort of building from there, I think may feel more feasible.
Mhm. Anything you would add, Dr. Fanfare, in terms of if somebody's not doing any of this right now, they're not having any of these conversations, how would you encourage them?
Tony said, I think it's trying out different things. I think for me, if I'm being candid, it took some time to get really comfortable speaking about these conversations with my patients or my veterans who are aging. Right. I mean, people who are aging and being comfortable and confident to have these conversations around sexual health is quite important. And so for me, it was really just being kind of candid and doing some of that inner work that I needed to do. And then just starting out with, tell me what's going on. At home, tell me maybe the last time you were sexually active. Oh, was that men, women, or both? And just really kind of starting from there. In those spaces, I think so many times it's about companionship. And so I think that those are the ways that we've kind of been able to link that it doesn't have to feel like the way, at least, I mean, Odie and I are pretty much the same age. So I think kind of taught in medical school, you're asking about smoking, you're asking about drinking, you're asking about drugs, you're asking about sex, like all at the same time. And if you can tell, that's all kind of framed under like the umbrella of risk, right? And so kind of teasing it out and bringing it to a broader conversations around companionship and partnership has been really helpful in those spaces.
I love that. Thanks for bringing it. What about you, Miss Leisha? What do you think needs to happen next? You talked about going beyond HIV providers. What do you want to see next?
I want to see the conversation about sexual health normalized. Some of that anxiety comes from this is not integrated into our overall assessments, just about health in general. And so the more that we see that happens, the more providers are going to be comfortable having the conversation. I mean, we can pull from our most recent epidemic with COVID. No one had on an assessment tool 5 years ago. Have you been exposed to somebody, recently diagnosed with COVID, right? That's a blueprint in how our whole medical culture shifted to include yet a few other questions, just a few, as a part of the assessment. Right. And then based on that, having providers then initiate that conversation with women. Dr. Fanfare mentioned something. We did not coordinate this, what I'm about to share. This is prime time news. I finally got my AARP card today. Yes, so I'm thinking about sex in a whole different way, right? As a woman who is aging. So according to CDC, I didn't put this label on me, but according to CDC, once you pass that 50 mark, you're considered in the aging population. And there is this assumption, thank you, Jay, shout out to AARP. But there is this assumption as if we are not sexually active. And so the conversation, if there's anything related to sex, is about menopause, right? And so I can be going through menopause and still have an incredible sex drive, right? And not know that I have all these tools available to me, not my grandchildren, not my children, but to me. And there is that stigma, right? At her age, we don't need to have that conversation. So to all the clinicians that are listening, or you work in a clinical setting, please let the entire office know that there are sexy senior citizens out here. We still getting it in, and we still need the conversation. Period. That's all I got to say on that.
Well, I appreciate you bringing all of those sexy senior citizens into our conversation today. I really think it's critical. It's so critical. And there was some data that came out that I think broke our heart in a lot of ways, that was talking about how many women living with HIV, and in particular older women living with HIV, who are not getting the care that they need. And for so many women, so many Black women, we know that a healthcare provider is the only place they might talk about HIV. And so if you are a healthcare provider and you are not offering this conversation, then you're missing the opportunity to just serve somebody and reconnect them to care in that way. And so I think in the same way, we want to make sure that our sexy senior citizens know their reasons and their choices and their options around HIV prevention. We want them to feel supported and encouraged and connected to HIV care wherever possible as well. So I felt compelled to bring that forward. We are moving into this third phase, third spot of our conversation, which is really to lift up some more resources that are available for folks in the work who are looking for tools to have this conversation in a different way. So I am really thrilled to introduce three outrageously talented folks and part of the Risk to Reasons movement, including Dr. Toyin Nwafa from ViiV Healthcare. She is our Senior Medical Director for HIV Prevention. Bridget Pecue, who is a part of the WELL Project and a long-term partner for positive action for women. And we are so super excited to have Ashley Sly here, who is from the National Network to End Domestic Violence, who is a Risk to Reasons grantee and partner working to train providers. So welcome. Hello, everybody. Welcome back. Thanks for being here. We're going to dive into some of the resources and some of the work that you all are doing to train providers. And I am going to turn it over to you, Toyin, first, to talk a little bit about the work you're doing around Risk to Reasons to train providers, and share a little bit of the highlight of that work.
Great, thank you, and thanks Amelia, and thanks everyone. Great to be here in this with this amazing panel. And for me, Risk to Reasons really personal, because I remember, I think it was about 2 years ago when I first heard about it, and came over to you, Amelia, about the work you were doing, and said, this is really exciting. HCPs need to know about it, and our medical teams here at ViiV Healthcare need to be really aware about what is going on. And I remember you coming to our medical meeting and really coming with Ms. Lisha, Ms. Tori, and Ms. Beverly to really talk about why it was important to reframe risk, the reasons to do that, and what we needed to do. And since then, it's been very clear that from the medical standpoint for HCPs, they need to be educated around the resources that are available, why it was important, and it is important for them to change the language and really going ahead with doing that. And so since then, we've done little dabbles where we did training with our team, but also then would talk about risk to reasons as part of our advisory boards and our medical education. And there was always this interest from HCP saying, we need more. We need more resources to be able to have this conversation, from HCPs who already were part of the movement, understood the need, but needed resources to be able to train their colleagues or their trainees, from HCPs who really hadn't started and kind of leaned in and said, well, this is really important. How do I do this? And so part of what we've done with advisory boards was to really convene a group of people, healthcare providers, to really hear from the Black women in the working group to say, as HCPs, the time is now to really be able to have this conversation, have the tools to do it. And, I, as a healthcare provider for over 20 years, we did use language that was traumatizing, that was stigmatizing, and really pushed people away. So it was really important that we kind of weave that into how medical conversations are happening. And one of the things that was a readout from this advisory board, which quite a few of the members are on here, was really doing a deep dive, listening to the Black Women's Working Group, talking about why, workshopping about what that would look like, but very clear that there needed to be a product from there to be able to continue the conversation. And so on the slide, you'll see the amazing, incredible team. And, shout out to everyone on the team, but especially Alfton Dyson, our PharmD and DEI equity lead, who really led this team of putting together this ViiV medical education. So as you can see, an amazing group of people from ViiV, and also especially external partners who really took apart our sexual health deck and said, if we're really talking the talk, we need to walk the walk. So we had public health people, people in clinical care, educators really looking at the way the deck would feel. And so this is part of our ViiV medical education team who really put together a product that brings the voice of the Black Women's Working Group into this conversation and makes sure that when we have women who are empowered and affirmed and having the conversation that they deserve to walk into healthcare spaces where they're seen and heard, that are safe, that are affirming, that are judgment-free, and they have the tools to be able to have this conversation. So really incredibly proud of the partnership of this team of ViiV and our esteemed external partners who put together a product leaning into the community conversations and really calling the HCPs to action, and really in a way that is affirming and giving people very practical, tangible ways to have conversations in their clinics.
Thank you, Toyin. I think it's a beautiful thing to have a partnership in our company that is solely committed to ending the HIV epidemic and moved by our mission to leave no one living with HIV behind, to see offerings from and with and co-created with community as valuable to changing the way we operate as a company and to what we can offer in the world. So thank you for your leadership, and thank you, Alfton, for your leadership, and thank you to so many of our ViiV colleagues across the company who move this work forward. I know you are excited about all the places that this new medical education can go. Before we get there and have you talk a little bit about that, I want to invite Bridget and Ashley back into the conversation. So Ashley, let's start with you. Can you tell us a little bit about the work that you're doing at the National Network to End Domestic Violence to train organizations and providers?
Sure. The National Network to End Domestic Violence is addressing the intersection of domestic violence and HIV, and particularly its impact on Black women. To date, since the start of our grant, we've hosted 3 listening sessions with Black women living with HIV who have also experienced intimate partner violence, and held 4 listening sessions with domestic violence and HIV service providers as well. With the listening sessions with Black women really focusing on what are the barriers to care, what are those challenges in accessing domestic violence services, the stigma that they're experiencing related to both domestic violence and HIV, and how is this intersecting and overlapping in their access to different care and services. Shout out to Dee Dee, who's on right now, Diane Granberry, who's set up these listening sessions. They've been incredibly empowering spaces and just really, informing to the work that we continue to do, and have led us down a path to creating a more formalized long-term group with survivors. We also offer free training to domestic violence and HIV service providers, really around improving service delivery. How do you build confidence in having these conversations and not being an expert? I think that's often this misconception is like, I have to know everything. And we always say, you don't. Just having little bits of knowledge and knowing where to turn can make all the difference when having this conversation. And hopefully what this ultimately leads to is more survivors and folks feeling empowered to engage in HIV preventative care, and hopefully be relinked to care if folks have fallen out of care as well. We know that domestic violence and trauma in general are barriers to care. So really trying to bridge the gap between the two, so these conversations can continue. But kind of acknowledging what was said earlier is we can't stop at domestic violence and HIV organizations and having these trainings and these conversations, that it really has to be this no wrong door kind of operation that we're kind of implementing.
And some of the work that you're doing is really, nestled at this important intersection of vulnerability that we understand. And part of what Risk to Reasons is trying to do is resource organizations working at these intersections of HIV and sexual health and some of the other social determinants that really drive women's circumstances. And so can you talk a little bit about how you've been sharing Risk to Reasons content with those that you're training and how folks are receiving it?
Sure. Yeah. So we do talk about this language change and reframing of risk, and really, I think we talk about it from this victim blaming perspective, which resonates with domestic violence service providers, and they seem to understand that risk is kind of this blaming way of looking at things, and looking at it more of an empowering light. So that has been a takeaway. I think historically also the domestic violence field has shied away from having conversations around sexual health and healthcare in general. But for a lot of survivors, they have been maybe removed from the healthcare system for a long time. So maybe they haven't had a pap smear in many years, or have maybe left behind their medication. So if we're not having those conversations with a survivor, they may not know how to access a new doctor, or may not know how to change their prescriptions to a new pharmacy, or any of those kinds of things. So just starting the conversation, or with kind of light touches, I think really is helpful, and people have kind of bought into that. And again, we always kind of say, you don't have to be an expert. We're not looking for perfection. And I think the biggest piece that I always try and drive home is this humility piece. Like, you don't have to know everything. Just coming to the conversation and being humble about it, and having empathy, and just saying, let's figure this out together, I think is so important, especially with survivors who have gone through so much, are in a vulnerable place, and just trying to survive day to day and heal.
I think your message around not having to be an expert is really so important. I think even everybody on this call probably has felt that place of, maybe I don't know enough to have this conversation, or maybe I'm not the best one to have this conversation. I think what you all have been bringing in the spaces where you've been bringing it, I think gives folks permission to not have to be experts, but to be aware of the role that they can play. And so I just really appreciate you and your team, and how thoughtful you've been in developing these resources and making them available. I know that folks can find them, and they will find them online, and can request some support from the National Network to End Domestic Violence as well. So thank you, Ashley, and the team there. I'd like to invite Bridget into the conversation. Bridget, welcome. Bridget, do you want to introduce yourself and the work that you do at the Well Project?
I do. Thank you for having me. I have to say, I love how involved everyone is in the chat. Like it's giving me life right now. So I'm Bridget Piku. I'm the stakeholder liaison for the Well Project. We focus specifically on women and girls living with and vulnerable to HIV. I'm a nurse in my other life when I'm not advocating, and I'm also a woman living with HIV. And so the work that we do is critically important to me and has a special place in my heart. One of our programs that we offer is our She, Her, They program. And She, Her, They stands for sexual health education, HIV empowerment resources, and treating HIV equally. So everything that we do has an intent and a purpose. Our programming is unique in that we provide resources for women who are living with or vulnerable to HIV, but we also provide resources for clinicians, right? Because oftentimes there's a gap between what people know and what people think they know on both sides, both of women living with or vulnerable to and clinicians. And so bridging those gaps are really critically important. One of our latest tools is a conversation guide and a set of infographics that are made specifically for clinicians in order to be able to have some of these conversations that we've been talking about, right? Like to break down some of the language barriers and break down some of the language gaps. I'm particularly proud of these resources because they were made with both clinicians and folks living with HIV. So it is definitely something that gives a dual perspective.
I think I lost Bridget. Is it just me?
As we talk about language justice is really important too, right? So you have to be able to meet people where they are. And in the
We may have lost Bridget. I think she's going to come back probably in full force in just a minute, but huge appreciation to Bridget and to the Well Project team for the resources that you've been moving with different provider networks for many years. We know that these tools help people walk into a doctor's office more prepared, and that helps the doctor's office themselves be more prepared for these conversations. They are easily accessible online, and so want to make sure that everybody on the line here has access to that link in the chat. Thank you, Bridget. Are you there? Are you back?
Did I get kicked out? I'm so sorry. I was like, wait, what happened?
It's all right. We can hear you. Go ahead. I think you were talking about how they were co-developed.
Yes,
When we lost you.
with both clinicians and women living with HIV, which is really, really critical because we need to be able to understand each other and bridge some of those gaps and the relationships that Dr. Blackstock and Dr. Fanfair and Leisha were all talking about, right? We have to be able to hear each other and understand each other to be able to have those conversations in a meaningful way. It's not just about spitting information or regurgitating or just asking questions, right? It's meaningful questions that matter and that are going to get you to a place where you can move forward with what we need. So super proud of our resources. I'm sure they'll be dropped into the chat. And with that, I will turn it back over to you. Thank you so much.
Thanks for doing this, Bridget. I appreciate it. Thank you for the Well Project team and all you're bringing. So I'm going to invite Dr. Toyin back to share one more bit around our ViiV medical education offering and pull people into that work. If we could have that one slide, please, where folks can learn a little bit more information, that'd be great.
Yeah. Thank you. I think it's up there. So really the QR code is for individuals, organizations to scan to actually learn how to request these ViiV medical education initiatives in your area. So just scan the QR code, or there's also a link in the chat to be able to sign up for that. Because when we've had these conversations around Risk to Reasons, the feedback we get all the time from HCPs is, you know, we need these tools, right, to be able to have the conversation. We wish we had it earlier, right? I wish I knew this language. I wish I had this language when I was in training, and that the goals and the values in out there are so empowering for women and for everyone. The guiding values and the principles are affirming, and that they want to translate that and really help in that conversation. And I think it's been shared over and over again by panelists that the normalization of the conversation and the self-care as part of overall care is really important. So prioritizing women's health, but also knowing that the multiplier effect of a Black woman is amazing. Having her understand the reasons for prevention and treatment and care really, really is for everyone in her community. So it's really important. And this is how you can request the Risk to Reasons resource, which was again co-developed by that phenomenal crew that we saw, and really a very tangible asset to be able to have conversations with healthcare providers.
Thank you. Well, this is an invitation. I think Dr. Peralta in the chat shared some resources. I know others have shared resources that they have used in taking sexual health histories and having sexual health conversations. If there are other go-tos that folks on the line want to put in the chat and share as part of this idea exchange to make sure that people know that these resources are there to support them, that would be great. So I'm going to close us up here by inviting everybody back on screen, if possible. And I'm going to do a quick round robin in terms of, and I'm going to change this up, but how about one word that you want to leave this movement with after this conversation? What one word do you think can really capture maybe what this conversation has meant to you, or where you want the movement to go as we close up? So let's bring everybody back on. As we do this, I also want to lift up the survey, the feedback survey. If you could show that slide to give us our feedback, that'd be great, and put it in the chat. We'd love to hear what you think about this conversation. We'd love to hear what you need to see in your community and the ideas that you want to offer to help us move this movement forward for the next iteration. So with that, I'm going to start, since I see you, Dr. Toyin. What's one word you want to leave us with here?
My one word is inspired.
Thank you. Certainly. What about you, Leisha?
My one word is do. We can all do something.
Yes, do something. What about you, Dr. Blackstock?
I would say empowered.
Mm-hmm. And Dr. Fanfare?
My one word is liberation.
Oh, liberation, please. The freedom. Yes, liberation. Bridget, what one word will you offer?
It's two, but I'm going to cheat and hyphenate it. Shared power.
That. Ashley, what one word would you offer?
I'll offer empathy.
Thank you. Olivia, master with words. What do you have?
My word for today, one of many, is vulnerability.
Vulnerability. Mm-hmm. Who am I missing here? Bev, what's your one word?
I'm sorry again.
What's your one word to leave us in this conversation, where you want the movement to go or what you're left with?
Oh, that's a good question. Access.
Access. So critical.
Yeah.
So critical.
Access.
And what about you, Dr. Smith? What's your one word to leave us with?
I'm mad at Oni because she took empowerment, because that was mine. But actually, though I would say care. We have to care, and I'll leave it at that.
That's right. That's right. Well, my one word will be disrupt. Please shake it up anywhere you can. Shake it up anywhere you can, even in a single conversation once. If you haven't had it before, just try, please try. And thank you for all of the effort that you are making. I know you are all here because you are trying and because this is important to you and that you do see the freedom and liberation for Black women connected to this work, and that you believe in all the reasons that we all share for helping make sure that women get the care that they need.